Hi everyone, welcome again to a new month. And thank you so much for joining us today as we present to you on the new Mpox variant Clade II. We are very pleased to have Dr. Shallington Mbuvi, who is a pharmacist working in Meru, Kenya, a friend of the Addis Clinic for a while now, and a very dedicated person to teaching and educating his colleagues. We are sorry to tell you that Dr. Paul Hart will not be capable of joining today. He had a medical emergency and requested as if possible we can continue without him. But even in his absence, we recognize him. Thank you everyone for taking your time and from your busy schedule and making sure that you join us today. The Addis Clinic, as you all know, the people that have managed to be with us for a while have attended our webinars. It's a non-profit organization based in Kenya and US and Somalia. We offer we offer different programs in all these countries. We have the telemedicine platform that offers these webinars and offers the global health courses. And the webinars are part of our enriching and educating the different healthcare workers in different sectors as we give back to the community. And then it is coupled with the telemedicine part where we offer synchronous telemedicine services to different clinicians all over the world. So whichever part of the world that you are in, you are capable of joining without a problem. The third one is the global health course that is partnered with the telemedicine, where we link up with different universities in the world. And we have managed to link up with 3 universities. Currently, we have linked up with Kenyatta University. We have linked up with Vanderbilt University of Medicine, of Medical Studies, and Pittsburgh University. And the second program now is on the mother and child health care that we do in the Somali part, where we work in 2 different ADP camps, Beledweyne and Mogadishu. And this is mainly to support the mother and child health in the IDP camps, where we have managed to help a bigger number of mothers and younger children and prevention of mother-to-child infections, and more so even deliveries. That program is the SRHR program in the coastal part of region, where we offer the girls health. We actually currently call it mother and girls health services, and these were girls safety program. And this one we work with GBV cases, sexual reproductive health rights. We we work with orphanages and schools to train young adults on prevention of early teenage pregnancies and guide them on cases of gender-based violence. The fourth one is the M Health, where we work with 6 counties in western Nyanza part of Kenya, where we offer HIV services and adherence program. We work with the counties and the Ministry of Health in these areas, and we offer services to follow up on the mothers in these areas and everyone that is affected by the HIV pandemic, and making sure that we follow up with them, give them follow up on their adherence program, and make sure that they don't miss their clinic days. So in a nutshell, all this is covered by the digital platform that we have. We have a platform known as Collegium Telemedica. So in case any of these programs need help in answering telemedicine cases or tracking and treatment plans of the cases, that's what we offer. So today, the webinar will be on Mpox. And I will give so before I give Dr. Shallington Mbuvi to to take over. I just want to inform you that the Q&A platform is open. So anyone that will be willing to, any question that you come across that you need help, please forward it in the Q&A section, and we'll be ready to answer it after the presentation. In case we don't have the answer currently, we'll forward it to you after. So we'll share your emails. We all have your emails that you shared with us. And if previously you joined any other class or webinar and you did not get the answers of the slides, please let me know. I will forward it to them. I forwarded them, but I think some of the people did not get them. So if you did not get the previous slides, please let me know. And it's 11 minutes past time. Dr. Shallington, the floor is yours. Thank you. You're on mute. You're on mute, Dr. Mbuvi. You're on mute. Okay.
Okay. So today we are going to speak about Mpox. We are going to talk about the clades. Then we are going to talk about the support treatment. We are going to talk about the rationale for Mpox. And we are going to talk about transmission, diagnosis, and the management. So I'm going to start. So Mpox, what is Mpox? Mpox, it was formerly known as the monkeypox. It's a disease caused by infection with monkeypox virus, and although pox virus, the incubation period ranges from 3 to 14 days or to 17 days, and it's through person-to-person transmission. Yeah, it can be indirect or direct contact with other contaminated beddings, clothing, or other objects. And Mpox is a viral infection that can cause symptoms such as painful rash, fever, headache, muscle ache, back pain, low energy, and swollen glands. Most people fully recover from Mpox, however, it can lead to serious illnesses among certain people, especially children or pregnant women or people with a low immune system. And all the patients suspected with Mpox have high risk of complication. Those, all people with suspected Mpox and those at high risk of complication should seek professional health care and monitoring in hospital or other healthcare settings. Most people with Mpox will recover at home. Home-based care for Mpox involves isolating the infected individuals to prevent the spread of the virus and providing supportive care to manage the symptoms. Then when we go to the rationale for Mpox, that is home-based care. So we have 4 types of home-based care. We have the preventive transmission, we go to the resource management, we go to the accessibility, and we have the supportive environment. So when we come to the preventive transmission, isolating, it involves isolating infected individuals at home, helps prevent the spread of the virus to the others in the community. Just the same way we were doing to COVID-19, we just do the isolation. Then we observe if the cases are complicated, they are referred to the hospital for further management. So in our resource settings where we have little resources, we have to check on the ways that we can reduce the cost instead of using a lot of finances to control. It's like if the infection is controllable at home, just isolate at home. So home care reduces the burden on healthcare facilities, allowing them to focus on severe cases and other critical health needs. Then when you go to the accessibility, in resource-limited settings, home-based care provides a practical solution for managing Mpox especially when healthcare infrastructure is inadequate. Then when you go to the supportive environment, being at home can provide a more comfortable and supportive environment for recovery, with family members able to assist in care. Then, this is a general view of the management of Mpox. When you get it, up to the facility where you are supposed to be admitted. Just like there's some cases that some people will get mild infections, and they will just stay indoors, then it will clear by itself. Some cases might be complicated, that needs to be taken to other health facility. The patient will be accessed, then probably they will be admitted for further management. So this is just a general pathway on how we are supposed to manage the Mpox. So we have the risk of severe diseases. Cases of Mpox are not life-threatening. However, some people may be more likely to get severely ill than others. And this includes, we have the people with a weak immune system, we have children under 1 year, and we have people with dermatological issues. Then we go to the transmission. The transmission can be through person to person, can be through animal to human, then can be through touching contaminated objects. So we are going to start with person-to-person transmission. This can occur through direct contact with infectious skin or other lesions, including contact which is through face-to-face, that is talking. That's where we advocate for people to wear masks, just the same way we are doing with COVID-19. Then we have skin-to-skin, that is touching, or maybe through having sex, that is can be vaginal or anal sex. Then we go to mouth-to-mouth, that is kissing. Then we go to mouth-to-skin contact, that is oral sex or kissing the skin. Then we go through respiratory droplets or short-range aerosols from prolonged close contact. The virus then enters the body through the broken skin, mucosal surfaces, or the respiratory tract. Mpox can spread to other members of the household and to sex partners. People with multiple sex partners are at high risk. Then when we go to animal to human transmission, it can be through bites, which you can get them through hunting or skinning or trapping or cooking or playing with the carcasses or eating the contaminated animal. Then through touching a contaminated object, that can be through beddings, through sharp injuries, especially like the needles. Then we have in a community setting where people probably go for tattoos in those parlors. Most of the time they share the tattooing machine, and most of them don't disinfect it. Then we go to the signs. We have a fever, rash, swollen lymph nodes, headache, fatigue, and muscle aches. However, there are some cases where those people don't exhibit the rash and the fever, but they still have the infections. So the rash starts as a flat red bump, which can be painful. The bump turns into a blister which filled with pus. Eventually, the blisters crust over and fall off. The whole process can last for 2 weeks. You can also get sores on your mouth, face, hands, feet, penis, vagina, or anus. Then something that you are supposed to notice is that not everyone with Mpox develops the above symptoms. You may experience symptoms in the following ways: rash with no symptoms, flu-like symptoms, and then rash. Some may not have rash, just the same way we are having COVID, where some people exhibited no signs at all, but they were having the infections. So these are just a general outlay of of the previous slides on the development of the macule. Then we go to the papule, then vesicle, then pustule, then scab. Then on the rash, I've talked about the rash, then how it develops up until it crusts. Yeah. Then we have the flu-like symptoms. Some people will experience fever, headache, muscle aches, and back pains, swollen nodes, respiratory symptoms or chills. I think these are one of the cases that we had in Meru. I think it was just a challenge handling such cases when the first time. So on the way to report, we have all the cases should be added into a registry. It should include the following information just for contact tracing, just the same way we are doing for COVID cases. We are doing contact tracing so that we can make sure all the people that are suspected to have infection are quarantined until they don't have the infections and are free from the infection also. Then in the documentation, you do the name, you do the cell phone, we have the address, the date of birth, gender, date of onset of symptoms. Then we go to initial clinic course, date first seen at the health facility, name of the health facility, location of health care facility. All those are for the purpose of contact tracing. Then those are the initial, this is just a survey that you are supposed to ask the patient, do you have fever, rash, something so that you can make sure you document all the cases, because not all the cases will be Mpox. Maybe the patient might be having maybe smallpox that is having the same symptoms with monkeypox. So it is always good for the clinician to do a thorough inspection so that they can know whether it is other infections or it is Mpox. That's the purpose of having this survey done. Then we go to the cases should have initial symptoms survey done. So in the survey, we usually document the total number of yes answers and track of it with each subsequent visit to the hospital. Then patient with any other symptoms that are severe should be immediately escalated to the healthcare facility. Patient with 2 or more moderate symptoms should be escalated as well. Any patient with confusion or seizures should be immediately escalated. Any patient who develops sudden onset of weakness or difficult speaking should be immediately escalated. So this is just inspection and documentation of the household living condition. This ideally to know whether they can handle, they can do the self-quarantine, because like you might be getting, maybe there's a family, they have like 10 kids, then they have 1 room. So it will be very hard for them to do the quarantine, because like the infection will just get more worse. So that's the purpose of doing this documentation, so that you can know whether it is a deal for them to do the quarantine at their home, or it is better for them to be taken to the health facility. So this is this for mild cases. For the people who are living in the right living condition, maybe you are too in the house, maybe you have your own room. So this is ideal for those people living in a spacious room. Yeah. So you have the daily check. You can check them through the phone, or do a video, or in person. Then repeat of symptoms survey. Not any worsening existing conditions. If symptoms escalate, you refer to a health facility. Not any improvement or resolution of existing symptoms. Not when all symptoms are resolved and recommend escalate for discharge or evaluation. So the purpose of this is just to make sure you are following the progress of the patient. If they have, maybe they have fevers, you can recommend maybe for paracetamol, or maybe Brufen for those who are not allergic, or for those who don't have any gastric issues, so they can use the painkiller. So it is always good to do the follow-up so that you can keep updated with the patient, so that any change in the infections is well noted. So that's like if the infection are worsening, the patient can be taken immediately to the health facility that is near. So we have Mpox diagnosis. Mpox identification can be difficult since it appears similar to other infections and the condition like chickenpox, measles, bacteria, skin infections, scabies, herpes, syphilis, and other sexual transmitted infections. So during testing, it's always recommended we do a DNA polymerase chain reaction test that we usually do on the fluids, on the skin. So you're just supposed to swap on the on the on the skin so that you can get the so that you can get the test done. And that is why most of the people probably they might ask why we are not doing the blood test. So the purpose of not doing the blood test because we have different strains of the virus. So it's like if you do the test, it will be very hard for you to determine which one is chickenpox and which other is the monkeypox. That's why we recommend someone to take specimen of the skin or the fluids or the crust through the swabs. Then blood. Okay, I've spoken about the blood testing, why it's not recommended because it will be very hard for us to distinguish between the other poxvirus because they are main strains. So we go to the supportive care. So the supportive care involves rest and fluids. You get enough rest, you stay hydrated and eat well. Then if you have some fevers, you can do paracetamol or ibuprofen to manage the pain or the fevers. Then you can also do the baths. You take warm baths with baking soda or Epsom salts. Epsom is magnesium. So we have salts for magnesium that can ease the itching and make the sauce a bit dry. Then we have the mouth sauce. You can do the salt water, or you can also do the mouthwash. Just make sure you gargle. Then we have the hygiene. You keep the skin dry and uncovered. Some people, because of the stigma, will make sure that the sauce they try to cover the whole face, the whole hands. Yeah, but that will worsen the condition. Then we can do the isolation. Remain in isolation and wear surgical mask until all lesions, crust are fallen off and a new layer of skin has formed. Then we can do the vaccination. Then we can also do antivirals, especially for the severe cases. Then we have the management of skin lesions at home. You actually you're not supposed to scratch because like the more you scratch, the more you are contaminated the other surface area. So the conditions can become worse by scratching because it's like just the same way you do like most of the viral infections, you can easily contaminate the other surrounding areas. Then clean the lesions as necessary with sterile water or antiseptic solutions. Wash hands before and after to prevent the infections. Do not cover the lesions. Then just like if you are going maybe outside, you can just do a slight cover, but not that tight, but just for a short while. Yeah, but it's not very tight. Then this is basically how you are supposed to do the skincare. Using antiseptic for the severe cases, how you are supposed to handle it. I won't go through that because I've already mentioned the preventive care. Then we have the do's that we're supposed to do, and then we also have the don'ts. On the do's, stay at home if possible in your own room. Wash hands often with soap and water or hand sanitizer. Wear a mask and cover lesions when you are around other people until the rashes heal. Keep the skin dry and uncovered unless you are with someone in the room. Then avoid touching items in shared spaces to avoid more spreading the infections. Then use salt water rinses for sores in the mouth. You can also use the seat baths as we have spoken in the previous slides. In case you have fevers, you can use paracetamol or ibuprofen. Then we have care of the skin lesions in Mpox. infections. I think we have spoken this one in the previous slides. This is just a summary of what we are supposed to do. You wash hands, you keep the lesions dry, do not scratch, use bandages, especially when you are in the room or probably you are traveling, you cover with clothing, wear long sleeves and pants to cover the lesions, especially when you are moving out. Then you take warm baths, you use salt water rinses, then you disinfect shared spaces. Then the don'ts: do not pop blisters or scratch the sores to avoid the spread. Do not shave areas with the sores, because by shaving, you will increase the spread also. Then avoid sharing items. Probably you are living with your brothers and you're using the same towel. You will get yourself the second Mpox patient. So we also need to do assessment for endo counseling, because like it's not easy. Because like if you have Mpox, someone will tell you, oh, my friend, you want someone and you had sex with someone, that's why you're having the Mpox. So it's always good to have the mentor counseling for those patients. You ask them question like, are you feeling depressed? Are you being abused? Are you feeling anxious? Are you being bullied? Because there's some people tell you, no, go where you got the Mpox, especially for the couples. Where do you get the Mpox? Kindly go and stay there. So probably you can be chased. So that's why it's necessary to have the mentor counseling, so that you can know whether the patient is okay, or probably you can take the patient to a safer place where they are mentally stable. Then we have CHW patient on visit follow-up. You are supposed to wear a mask, you wash your hands, you do continuous assessment to the patient, then you practice IPC, then you this infection prevention control, the IPC, assess for accuracy of the severity of patients, observe for others members or also exhibiting symptoms. Yeah. So patient education, when you return to the health facility. So those are the things that you're supposed to do to the patient if they return to the health facility. That is, if they have worsening fevers, new eruption of the rash and controlled pain, development of new symptoms like seizures, weakness, and confusion. Yeah, then if some factors like environment, if there's change in the environment, factors like water supply, yeah, because there's no hygiene, so the infection will worsen because there's no enough water that you can do the proper hygiene. Then we have household occupancy change with high risk. So it's like if you have a small room and maybe you have 10, you need to be referred to the health facility so that you can be quarantined in a place where you are safe to avoid much infections. These are preventing the spread. You avoid close skin-to-skin contacts with people who have a rash that looks like Mpox. Learn what you should do to lower the risk of contracting Mpox during sex or social gathering. Just the same way we were using the mask. If maybe you are staying with someone and probably they are healing. Actually, they are almost healed. So that's why you can use the condoms if you cannot abstain to avoid more transfer. You can also do the vaccination, yeah, to make sure that the infection does not become worse. If you have conducted Mpox, isolate at home or in hospital for the duration of the infection. That is almost for 2 weeks, the same way we are doing for the COVID, so that you can make sure that you don't have any infection, especially if you try, like if you had maybe contact with the person who had Mpox. And there's something that I forgot to say. We have 2 types of Mpox. We have Clade 1, and Clade 1 as 1A and 1B. And we have Clade 1 and Clade 2. That as 1A and 1B. That is both Clade 1 as 1A and 1B. Then for the Clade II, we have 2A and 2B. Clade 1 is the worst. Clade 2 is the common one that we are usually having in our country. You get it, then it with the time it clears. But for Clade 1, it's not common, but when you get it, it's very dangerous. Probably you may not make it. So I think I've covered nearly everything. So we are going to the questions. I think Anthony will take us through the questions. If maybe you need some clarification, you can feel free to ask.
Yeah, thank you, Dr. Mbuvi. I think you're on time, and for everyone that is in the attendance part of the participants, please ask questions. In case you don't get even the answers today, we'll respond to them later. But we have the first question is from Steven. Should the skin be broken for one to get the disease in contact? How does the disease present in the mouth? Dr. Mbuvi?
Should I do one question at a time?
Oh yeah, you can do a question at a time.
Okay, no problem. I was looking for a pen to write the question, but okay, no, we can.
I can write them down and then I'll forward them.
No, I can do one by one, no problem. If they want to answer like that, because like just to avoid replicating the question, you can just do the question, then I answer them whole, just to avoid the repeating the same question.
So I think we have 4 questions that we can easily go through them. The first one is, should the skin be broken for one to get the disease in direct contact? I think the question is asking whether do you need to break the skin so that you can get into contact with the disease so that you can treat it as it is, or how does it present in the mouth? The second question is, how do you differentiate between a mild, moderate, or severe case of Mpox? The third one is what's the prognosis? What is the prognosis of a severe case of Mpox? And I think the last question was, what's the incubation period of Mpox?
The incubation will range from 3 to 2 weeks. That is 3 to 14 days or 17 days. Then on the first one, that the question about should the skin be broken? We have said we have several transmissions of Mpox. You can get it through kissing. You can get it through talking, through the aerosols. So it is not necessarily that you do the skin-to-skin contact so that you can just get the Mpox. Then we had there's a question. You can read for me the question 2 and the question 3 kindly.
Yeah, so the second question was, how do you differentiate a mild, moderate, or severe case of Mpox? How do you differentiate the three?
I can answer that. You see, for severe cases, you still notice through if the patient, like there's a patient who will just come and will tell you probably they have few rashes, go on to go to their homes, get themselves quarantined. Then after they get quarantined, the infection will clear by itself. But there are some other cases that you get the patient has a lot of pain, they have high fevers that needs to be admitted. The patient have a lot of rashes and the blisters. So those are like we have like these cases, which one? Case like this one, you cannot manage this case in the house. So it's like we have the mild case where the patient does not, it's like probably if they have fever, they can take painkillers and the fever will go away. some people will just take some, they'll just apply some creams, or they do beds with antiseptic, and the infection will clear. So those are the mild one. But when the infection are very severe, you'll see like this one, they have a lot of blisters. Then the fevers are not going down, and it's like when you do the observation, you'll see this patient cannot be managed at all. The other question was about the
prognosis.
So about the prognosis, I think you can you answer that one, or I can answer? At least you
Yeah,
answer.
so I think since the cases that have come through Meru, and I think there were 2 or 3, on the prognosis of severe case of Clade II, as Dr. Mbuvi told you, Clade I is not common in our side of. It's common in the western part of Africa, but not common in the eastern part of Africa. The one that we have, Clade II, the prognosis of a severe case like that, this one is high if we handle the symptoms. So in such a case, the one indicated in the screen, we can say that we have a 80 to 90% recovery rate, and it's not that common to lose a patient through an Mpox condition, because if it is caught early, or if in such a case caught late, and you have a severe case of it as shown in the screen, isolation and treatment of the empirical treatment of the condition is one of the most effective ways of handling the situation, to make sure that the patient does not transmit to others, and to make sure that you treat the symptoms and signs that you see. As you have been told, if the lesions are in the skin, treat the skin. If the lesions are in the 1%, the private areas, treat the lesions in that area accordingly with seeds buds and the Epsom cream. And if the condition is in the mouth, gargling of antiviral gargles is recommended too. And on the symptoms of high fevers, we control by giving sometimes even cold baths, and putting them on antipyretics. And when we say antipyretics, we don't go to the extremes. We go to paracetamol, brufen, and acetaminophen, and cyclophenac sometimes, but it works best. And in these conditions, we find that while you start treating, if you look at the third picture, from the first picture to the third picture is showing the drying of the lesions. So that's the plan that we work towards too. If you start seeing the drying of the lesions, it shows that then the body has created the antibodies to fight it. The body has started working on the antibodies to fight it. It's, as Dr. Mbuvi said, it's more of the way that we see chickenpox. Sometimes the chickenpox in children can be very severe and can lead to admission. But in such cases, we find that if you treat it empirically, because sometimes it's so hard to say that you have treated chickenpox. In such a case, an Mpox case, we treat empirical. We work empirically to make sure that the patient is handled on the signs and the symptoms that you are seeing, and we have a good prognosis, a 90% prognosis of the cases, and the fact that we have low case numbers, we can see the number of cases that we see in our areas are easily treated by the health facilities that you present the case to. And the reporting system has been improved in the sense that if you are in a low level facility, level 1 or level 2, it's so easy for them to follow up with the disease surveillance team and make sure that the patient is isolated. Thank you. I think that answers.
Yeah. Very well. Yeah.
Dr. Mbuvi, we are on time, and those were the only 4 questions that we had in the chat. And I think in case anyone else has a question later, my email is anthony@addisclinic.org. My phone number is 0712559438. In case you have a question on Mpox, in case you have a question on any other condition that you think that we may cover, Dr. Mbuvi and Dr. Paul Hart will always link up and try to research on it and give you a good presentation on it. And as the Addis Clinic, we are always ready to help in case you need us. And for the ones that are in the group or in the attendance participant list, and you wish to be part of us and join us through the telemedicine platform, refer cases to us, and follow up on your patients through our platform, please reach out to me too. I will create an account to you, guide you on how we use our platform, and send cases and help your patients in any way that you are possible. In case you need any other help besides that, if you are in the western part of Kenya and you would like to know how we offer our HIV services, reach out to me too. My email again is Anthony, ANTONY @addisclinic.org. Dr. Mbuvi has been with us for the last few sessions now, and he has been great in consulting, following up with the patients, and working with Dr. Paul on different presentations. So thank you, Dr. Mbuvi. And in case you need a new topic or you have a new topic at the back of your head, please reach out to me. I will consult them. They will prepare a presentation, and we will choose a date to present to you. We do this on a monthly basis, so you will be getting our emails, our WhatsApp messages, our messages through Jumbe, and informing you that we will be having such a presentation any other time. Reach out to me in case you need anything. In case you have any question, please let me know. I will have the email list for everyone that has attended today, and I will forward to you the presentation. The question asked, I will give Dr. Mbuvi to answer them in a systematic way, so that every one of you can go through them again. In case you go through the slides again and come across a question that you need answered, please let me know, and I will forward to Dr. Mbuvi to give an answer and forward to you back. Thank you so much. I think I will give John, our executive director, to hand it for us. And thank you all for attending.
Yes, thanks everybody for attending. And thank you especially Dr. Mbuvi for this fine presentation, and hope everybody has a good rest of the day.
Thank you, everyone. Bye-bye, everyone.